Ma'am, it hasn't gone live yet. So just a minute while I set it up. There is a separate link for the audio.
Good afternoon, everyone.
Good afternoon, madam.
Good afternoon.
Madam, how to set the background?
Good afternoon, everyone.
If someone is not able to put the background, it is okay. If she is comfortable, then also it's okay. Otherwise, if not possible, don't be.
Is
Can you
it
suggest
some
how to put the
particular?
background?
So we are live now.
But how to put the background? I'm not able to understand. God.
किनारे पे जाइए दीदी, 3 डॉट हैं, उसको टच कीजिए, वहां से एक बॉक्स खुलेगा, उसमें आपको मिलेगा हाउ टू.
अच्छा, अंजू दीदी, अंजू मैम बोल रही.
So welcome everyone to this second episode of Twilight by Raipur Menopause Society. Really very honored to have such dignitaries here. So this Twilight is designed for the second Thursday of every month. We would start by praying to the divine because that is how things move forward. Because of copyright issues, we will be reciting the mantra ourselves and we would just hold the hands together to start the prayer. Om Asat Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarva Karyeshu Sarvada Gajananam Bhutganadi Sevitam Kapit Jambu Falacharu Bhakshanam Umasatam Shok Vinashakarakam Namami Om Asato Ma Sadgamaya Namaso Ma Jyotirgamaya Mrityor Ma Amritam Gamaya Om Shanti Shanti Shanti. The organizing team of this webinar is myself, our secretary, Dr. Shalini Jain, and the treasurer, Dr. Monica Pathak, with help from the whole family of Raipur Menopause Society. Over to you, Shalini. This is our own team, so a very short introduction would do.
Yeah, it is my pleasure to invite and introduce Asha Didi for the webinar. She is a director of SMSA Hospital, Raipur. She is a medical director of Cancer Prevention Relief Society. She is elected member of CG Medical Council, and recently she has been elected for Foxy Food and Drug, Medicine and Surgical Equipment Committee. She is a president Raipur Menopause Society, and to her accolades, there are so many achievements and awards, but I will not enumerate because we are running short of time. So I welcome you all on the board, Asha.
Thank you, Shalini. And now I would like to welcome Shalini, who in spite of all her personal issues has been able to put this whole program together. I'm really very thankful, Shalini. She is an MD, FICOG, FMAS, SIMP, ACLS. She's a gold medalist. She is director and consultant of Saubhagya Mother and Child Care Advanced Gynec Endoscopy and Infertility Center, Shivanand Nagar, Raipur. She has been practicing high-risk obstetrics and gynecology since 2003.
Thank you, Asha Didi.
We also have Dr. Monica Pathak, who is the treasurer of Raipur Menopause Society and also the president of Raipur Obstetric Gynec Society. She was previously the secretary and also the treasurer. She has a keen interest in obstetrics and endoscopy. Our chief guest today is Dr. Anju Soni ma'am, who is the IMS president. And also today, I would like to honor her and congratulate her on her win as Vice President Foxy from the West Zone. So, ma'am is a very humble and loving personality. She introduced Dancercise. She is the President IMS 24-25, Secretary General in 22-23, elected Governing Council member of ICOG 23-25, member India CCM 22-25, Chairperson HIV/AIDS Committee. She is now the elected VP-elect 2026. She has helped design the Foxy Focus, Foxy GCPR, many articles and books of Foxy and IMS, and has released new updates and technical guidelines of HIV positive in the pregnant. She has very many awards like the IOG Excellence Award 2024, Alumnus Alumni Award 2023, Chikitsa Vibhushan Award, Best Committee Award for HIV and AIDS Committee, and Appreciation Award for unwavering commitment and dedication by NICO. What I would like to really tell friends is that when I had a problem about a young patient who was HIV positive and needed some help, she was there when she was chairperson in an instant and was able to guide me whom to take help of in Raipur. So she has been so much in touch. So over to you, Anju ma'am. We welcome you to this webinar.
Thank you for a kind introduction. Asha, I have always seen you are very hardworking. And I'm very happy that you have taken over the reins of Raipur Menopause Society. And I'm sure with your hard work and diligence, Raipur Menopause Society will see another heights in coming time. And I'm sure today the topic you have chosen is also very, very crucial. We all know that cardiac health in menopause is basically it's very critically important because menopause brings hormonal changes that can increase women's risk of cardiovascular disease. The cardiovascular disease is the leading cause of death among the women, and its risk rises significantly after menopause. That is why it is very, very essential to talk about it. And in 2023, there was a release of white paper by International Menopause Society, where they felt that the cardiac diseases in women are underdiagnosed, under discussed, and under researched, and there are different issues which should be directed. So multiple organizations from all over the world came together and they said that in next 5 years till 2030 they will look into it, because the differences between the gender bias are still existent, which were there for last 10 decades, and that has to be looked into. So they brought in this white paper. And also we know that the hormonal changes in heart risk, that is the estrogen decline, is the most important cause of the cardiac problem, and its protective effect on the blood vessels is very well known to all of us. It dilates the blood vessels, prevent the vasculothelial injury, inflammation, and when there is deficiency during the menopause, and the levels drop, and all the problems which occur are there in this menopausal woman. And there are other issues which are also very crucial for women, because their blood pressure and cholesterol also rise. And these postmenopausal women see often a rise in blood pressure and cholesterol level, both of which are again major risk factor. Again, because of the weight gain and fat redistribution wherein there is a rise in the visceral fat and the abdominal fat, which becomes from pear shape to the apple-shaped body, that affects the metabolism and brings in inflammatory factor. And these are responsible again for the heart disease risk. And heart disease risk also are because of the coronary diseases, that after the menopause, there is a change in the not only heart disease but also in the stroke, atherosclerosis, and the women have silent symptoms which are different from the typical symptoms which are present in the men, and then these symptoms can be missed by anybody because they may experience indigestion or a fatigue or an anxiety rather than a typical chest pain which is seen in the men. And so we need to look into the lifestyle prevention and preventive strategies, from diet and exercise to stopping of smoking and alcohol to management of stress, and of course prevalence of rising awareness is very very essential, and education is the most important part. And I'm sure today's speaker Dr. Sudha and all the panelists Dr. Sudha will cover this cardiac health issue very very well, where she'll talk about how it is important and pertinent for everyone to know about it, and how we can, what are the risk factors and how we can take a preventive care in this woman, and how uh, the awareness is very very important for all of us to know about. And also there will the panel moderated by Asha will also delve deeper into all of the problems which women face in the. So I would like to congratulate the Raipur Menopause Society along with the office bearers who have taken this torch of education uh, together, and they are also releasing a newsletter today. Dr. Asha, how do you want to release the newsletter?
Dr. Venya, are you there?
Yeah, I'm there.
Yes. So if you would share the screen, and Anju ma'am, because this is a virtual release, I would request you to just, read out a bit. And
Yeah.
Madam, can you see the
not yet.
newsletter?
Yeah, now we can see it.
We can see it, but it's too small a word
Okay,
to
okay.
be read on my mobile. I think somebody
You need to
will
make
have
it
to.
bigger.
Can I read it, madam, so that they can?
Yeah, please you read it, because you have talked about breast examination, you have talked about the ocular health in this, and
No,
you
ma'am.
also
This
talked
one
about
is
the.
only on the breast. This
Yes,
was
and
last
you have
month's
talked about
newsletter. So it's
yes, steps
on
in breast
August.
self-examination. Yes,
Yeah.
you have talked about breast examination, and it's very, very crucial to talk about the breast examination, because I feel that we can prevent breast cancers also by diagnosing them early. And one of the most important steps in early diagnosis is telling your patient about breast examination, because I feel it is a right of a woman to talk about the self breast examination, how it is done, and how they can themselves see, and if there any doubt, they can come to the physician themselves. And we should also not leave any opportunity when a patient comes to us for any other thing, any other problem, that we should examine the patient's breast and tell her how to examine the breast, and also look into her breast if there is any problem of any kind, so that she can find it at the earliest.
So
Congratulations
thank
to
you.
you for this very, very important step taken by you.
Thank you, Anju
Yeah,
ma'am.
I can just say.
Vinya,
few
would you
words.
like to say something?
Yeah, few words. Under the able guidance of President Dr. Asha Jain Madam, we thought of starting this activity. Every month we assure a newsletter at the end of the month, so that we can cover all the activities of the month, and also write something about the official theme topic of the month for menopausal activities of the month. And in that, we would like to also highlight the achievements of RMS members, if there are any. Like this one, we had 15th August, we had a group dance competition, national patriot. RMS stood first on the national platform, group dance. So we have shared the photo. In the second page, it is there. I'm not able to go actually. And then we will be sharing some information to boost the health of menopausal women. And the entire idea is just to promote the participation of members and increase the cohesion among members. We'll share about their achievements, our team achievements, as a whole RMS achievements. and make it little colorful and attractive so that everybody is interested to read. And most importantly, I would like to tell about the heading, Twilight. Twilight is the light between the day and night. That is the dusk time. In Hindi, we call it Goduli. And menopause signifies the Goduli of life in women, neither early, neither too late. So we want to make it colorful. And that's how our newsletter will include some colors and attractive sometimes. This time we have kept it little small, respecting the tragic incidents of the Calcutta Car Medical College. So we have only kept up to the theme topic and some diet and fitness issue topics. But later on, we may add maybe some humor also, some variety we'll add and make it interesting everyone. Thank you.
Thank you so much, Vinya. A few
Thank
comments
you.
from you, Anju ma'am, before we take the program forward.
Congratulations to you, dear. And
Thank you.
I hope it's a good start and it's going to end in a big way. Congratulations to you once again.
Thank you.
ma'am.
And we were thinking of, making it in Hindi as well. This time it was the first attempt, so we were not able to do it. So we thought we would have it in Hindi and English, because this information, the breast self-examination, the diet, the exercises for breast health is for everybody. So we had planned to do it this way so that it would be available for everyone.
And I have Dr. Saurabh Guptare. He is joined with me. Two of us.
Hello.
Okay. Thank you so much. Vinya, if you would please stop sharing. Thank you for all the effort.
Yeah.
Thank you for all the effort.
Thank you.
And now I would share
Thank
my
you, Vinya,
screen
madam.
again to introduce our chairpersons. Thank you, Anju ma'am. Thank you for your precious time. So Dr. Vinya Mayaskar and Dr. Saurabh Birthare are the ones who made this. Dr. Vinya is a consultant at Sri Narayana Hospital, has an Avani clinic, and she is a peer reviewer in Jogi and Journal of MedHealth, life member of many associations, and she has also written a book, Home Care in Parkinson's Disease. So this is our editor, and this is Dr. Saurabh Birthare, a young gynecologist practicing in Champa, who has been helping to put the material together. He is working as a consultant at Birthare Nursing Home and Maternity Hospital, Champa, has trained from Iron Donor School of Ultrasound, has done IUI and infertility training from Ahmedabad, colposcopy training from Guwahati, and is an invited faculty in many conferences. So this was our editors, and now we proceed with the scientific session. I would request Shalini to give a brief introduction of all our chairpersons, and then they would introduce the speaker. I've already introduced Monica, so you can proceed.
So it is my privilege to introduce Dr. Jyoti Jaiswal. She is a professor and HOD in Pandit Jain Medical College, Raipur. She is National Treasurer of IMS. She is Vice President CGSR, Secretary General Raipur ISOPAR, and she is Treasurer Chhattisgarh IAGE. She has organized many conferences. She has published book on quiz on menopause in 2021. She has written many chapters in POXI and IMS publications. She has written chapter in postgraduate textbook of gynecology. She has presented 35 papers in national and international journals. She has various chapters in the peer review of Journal of Midlife Health Women. She has various awards and recognitions to her accolades. Foxy Achiever Award 2023. She has received NICA Award 2022. MS Signature International Award in 2022. Dr. Suvarna Khadilkar IMS Best Committee Award in 2021. CG Medical Teacher Associations Award in 2021. Lions Club Shikhar Award in 2018. And many more to her CV. I really welcome our own beloved Dr. Jyoti Jaiswal, madam. And I really welcome
Thank
Dr.
you,
Rupali
Shalini.
Verma. Thank you, Didi. I really welcome Dr. Rupali Verma. She is a very senior consultant OBGY at her own hospital, RS Polyclinic and Diagnostic Center. She is a very good and very ethical and very honest person, and I'm really happy to have her in my this webinar. Now I welcome Dr. Sushma Verma. She is Director Consultant and Sarvodaya Hospital Maternity Center and Test Tube Baby Center. She is also a very senior practitioner, and she has achieved so many this thing at her very young age. She is President Raipur Menopause Society, and she has just completed her tenure, and she has done wonderful job. She is Treasurer Raipur Obs Gynae Society in the past. She is Treasurer IFS CG chapter, and now she is also Vice President in our ROGS. She is Executive Member of CGSR. She is past Secretary, Raipur Menopause Society. She is participant in various conferences and as a speaker, panelist, and chairperson. She is chairperson for Digital Education Committee, and various fields of interest are laparoscopic surgeries, high-risk pregnancies, menopausal health. I really welcome Dr. Sushma Verma, and I am happy to
Thank
have
you,
her in our...
Shalini, for the kind introduction. Just I want to update ki I am the immediate past president of Raipur Menopause Society.
Yes, yes.
And now, actually, this is the old CV. What I have sent was the new one.
Yeah,
And at present,
told
I am the
that.
vice president of Raipur Obs and Gynae Society, and Dr. Asha Jain is the president of Raipur Menopause Society.
Yes, yes.
So thank you very much.
Yes.
Jyoti Didi, may I take the privilege of introducing Sudha, our own Sudha Sharma ma'am?
Go ahead, please.
It's very pleasure and with great respect, I want to introduce Sudha Sharma ma'am. She is the Vice President IMS 2024-25, Secretary General of IMS 21-22, Honorary Professor of IMA. She is the Managing Committee member of PCOS Society of India, Editor-in-Chief of GMS 2016 and 18. She is the member of Editorial Board, Editorial in General and Members, National Advisory Board and Journal Committee. She is the Chief Editor of Clinical Update and on Osteoporosis and Associate Editor of International Journal of Obs and Gynae from 2007 to 2012. And she is a faculty member consensus document on menopause and osteoporosis IMS. She was the president of Jammu Obs and Gynae Society from 2018 to 2020, founder president of Jammu Menopause Society, and she had around 90 publications and edited various books and chapters in various books. And it is a proud privilege for Raipur Menopause Society to have Sudha Sharma ma'am as the speaker, and she is actually the torchbearer for all of us, and she is the guiding force behind many of the IMS projects. So, most welcome, ma'am.
Thank you, Dr. Sushma, for such kind words and kind introduction. So, at the outset, I really want to congratulate Raipur Menopause Society, Dr. Asha and your team, Dr. Shalini, Dr. Monica, and huge congratulations for releasing the newsletter. And I am finding it's a big commitment. You said that every month you are coming out with a newsletter. So that's a great thing. 3 cheers for you and your team. So with the respected chairpersons, I just want to share my screen. Is this visible? Hello.
Yes, madam.
Okay.
Yes.
Am I audible?
Yes, ma'am.
Yes.
Okay. So to start with, and I think you invited, one cardiologist also. So speaking in front of a cardiologist and that too a gynecologist is, I know how good I'm going to do it.
Ma'am, he has not yet joined.
Okay. So let us know some very, small, interesting facts. Human heart grows through childhood, reaching its full size when a child stops growing. When you are a kid, your heart is about the same size as your fist. And when adult, it's about the same size as of two fists. Our heart beats about 100,000 times in a day, 35 million times in a year, and with average lifetime, this beats about more than 2.5 billion times. Now, let's see, do we have any, relationship between heart and emotions? If you look at this, kind of poetry, you must have heard, कभी कभी मेरे दिल में ख्याल आता है, तुम होती तो वैसा होता, तुम होती तो ऐसा होता. तुम ये कहती, तुम वो कहती, and all this. What is this all has to do with our heart? No, it is proved beyond doubt that our emotions and feelings, they have diverse effect on autonomic nervous system that can result changes in heart rate variability and contractility. And all this is because of the release of cortisol and adrenal rush. Now, these emotions and feelings are the same for both men and women. Their hearts beat in a similar way, but there is a difference in male and female heart and their cardiac system. We know that premenopausal women are at lower risk of cardiovascular disease as compared to men of similar age. And this protective effect is attributed to estrogens. And let's see how. The protective effect of estrogens comes by improving the lipid and carbohydrate metabolism, by regulating coagulation and fibrinolysis. Estrogen has a direct short-term, and I think there's somebody
Some
has
echo
joined.
is
Yeah, somebody has
there.
joined with two devices. Somebody has joined with two devices. So,
Shalini, please check.
so by regulating coagulation and fibrinolysis, it has direct short-term and long-term effects on the endothelial system and the vascular smooth muscles. We have, estrogen receptors, the regulation of gene expression, which could be by intranuclear and extranuclear actions, and the beneficial effect on blood lipids, lipoproteins, homocysteine. At all ages, at any given point of time, HDL values in women, they are more than men by 10 milligram per deciliter. That is before menopause. And this is because of the estrogens. So it has a positive effect on endothelial cell function, relaxation of the vascular smooth muscles, decreases platelet adhesion aggregation, and effect on coagulation and fibrinolysis. They are antithrombolytic, and also it acts as antioxidant. Estrogen promotes and maintains gynecoid body fat distribution. It improves glucose insulin metabolism, displays anti-inflammatory effect through cytokine production. Now, this protective effect would cease as a female enters into menopause. So her risk of developing cardiovascular disease becomes twofold higher and more if her menopause is premature. So women tend to develop cardiac disease about 10 to 20 years later than men. But this 10-year advantage in them would be lost if she has a premature menopause or if she has risk factors like diabetes, dyslipidemia, and smoking. Now, CVD has been reported to be the most important cause of death in women in India by, the Registrar General of India, Home Affairs, GOI 2009, and also a report from US National Mortality Record of 6 largest Asian subgroups. From 2011 to 23, they review that there is a significant difference in cause-specific death with highest cardiovascular death rates among Asian Indian women, and this is a matter of concern. Now, there is a difference between men and women cardiovascular disease, and let's see how. The pathophysiology of atherosclerosis is different in women when we compare it with men. Women have higher risk of blood coagulability, hence they are more vulnerable to formation of thrombus. In women, endothelial dysfunction, small vessel size, and diffuse atherosclerosis are major cause of ischemia. These atherosclerotic plaques in women, they are less fibrotic, they are soft, they are lipid-filled foam cells, and hence they have greater potential for reversibility. But on the other hand, when they are soft, they have more chances of plaque rupture and formation of thrombosis. Now, women are much more likely to have atypical heart attacks, as has been reported by Dr. Lily Broach also. They are more likely to get less common symptoms as indigestion, shortness of breath, backache, and sometimes even absence of obvious chest discomfort. So according to Y study, they are more likely to have microvessel disease, which does not show up on angiograms. Hence, they are often underdiagnosed, undertreated, with poorer outcomes than men when it comes to the cardiac disease. Now, what are the various risk factors in females? GDM, all along our life, at least I have been telling my patients that if you are diabetic during pregnancy, you are having a risk of having diabetes later in life. But I never knew that they are also at a high risk of having cardiovascular disease if they are GDM. If they have gestational hypertension, again, more chances of having CVD in later life, which is linked to insulin resistance and dyslipidemia. Then PCOS women, they may have several CVD risks such as insulin resistance, high LDL levels, central adipose tissue, hypertension, elevated homocysteine levels. And the changes which are found in this PCO females having cardiac disease are their LVH, increased left atrial size, diastolic dysfunction, coronary artery, calcium scores, and even carotid intima media thickness is more. Genetics. We all know that genetically, the females, they are prone to, heart attack, and there are two polymorphisms which are associated with MI. Hypertension, anybody having hypertension with, systolic more than 20-degree increase and 10-degree increase in diastolic will increase their cardiovascular mortality. Diabetes, twice CVD is as common as in females who do not have. Metabolic syndrome also has an overall negative impact on the CVD disease, which worsens the prognosis in them. Anemia, lower hemoglobin levels, they have been linked with adverse CV outcomes. Depression, according to Women Health Initiative study, has been found an independent predictor of coronary artery disease. Smoking, more number of cigarettes, more cardiac events. And if she stops smoking, the CVD risk would decrease by 50%. Obesity, increased BMI, 37% increased risk of having cardiovascular disease. Now let's see what are the markers of CVD. How would we know it that this female is going to have CVD or has CVD? Lipoproteins, they are the validated markers of CVD. And these plasma lipoproteins based on their particle size are classified as VLDL, LDL, and HDL. We all know very low density lipoproteins which contain bulk of triglycerides on them. LDL are most cholesterol rich, and HDL contain 50% protein which acts as scavengers of cholesterol and thus is known as good cholesterol. Apolipoproteins, circulating lipoproteins that transport lipids to and fro from the liver and to other tissues. Apolipoprotein A is a protein constituent of HDL, hence good apolipoprotein, whereas B is a protein constituent of atherogenic LDL and VLDL. Dyslipidemia, dearrangement of one or more of the lipoproteins is implicated as a strong risk factor of ischemic heart disease, and that is more noted in Asian Indians. Hyperhomocysteinemia, independent risk factor for CVD and is known to increase with age, menopause, smoking, deficiency of 6B6, 12, and folic acid. C-reactive proteins, increase in this inflammatory marker also increases CVD, which is limited to arterial disease only and not to venous disease. Now, because estrogen protects cardiovascular disease in premenopausal women, with the same idea, HRT was being prescribed, or rather I would say it was, being taken on counter from 60s to 80s, presuming that menopause is a hormone deficiency state. It is curable, it is preventable. You take hormone replacement therapy, you will be feminine forever, you will be healthy forever. Till 2002, after publication of WHI results and HERS trial, that is heart estrogen progesterone replacement therapy trial, they said that no HRT to be given for primary prevention or for secondary prevention of coronary heart disease, as it did increase the rate of cardiovascular events and thromboembolic events. But having said that, menopausal hormonal therapy has beneficial effect on the cardiac health also. And how it is? The protective effect of MHT on CV health stems from its beneficial lipid modulation as well as estrogen's favorable action on the endothelium and vasculature. We all know it. Thus reducing the risk of coronary artery atherosclerosis, but only if started in women less than 60 years or within 10 years of menopause in absence of contraindications. Why? Because as compared to older women, these women in this age group, they tend to have a better baseline cardiovascular health, lower CVD risk, lower coronary artery calcium scores. So we can prescribe MHT if it is not contraindicated in these females. Now, how do we evaluate the risk factors? History, physical examination. We all know we have been, teaching and, studying and teaching our undergraduates, postgraduates, and risk assessment models. We have various risk assessment tools which have been, given by World Health Organization and International Society of Hypertension. I will not go into the details of these, tools. They have certain limitations in them. Then we have, a CRD chart also, that is South Asian region risk prediction charts that predicts 10-year risk for cardiovascular disease event for India. And there are 4 sets of charts, 2 for males, 2 for females, 2 with presence or absence of diabetes, and 2 with or without cholesterol readings. And these are the charts. They are very much available with us, and wherein we have to, fill in certain parameters like the age on one side, the blood pressure on the other side, and the cholesterol levels. And then we would come to know what is the, risk factor for this female for next 10 years. So if she falls into the low risk for cardiovascular disease, then menopausal hormonal therapy is safe in this woman. If she falls into the moderate risk for cardiovascular disease, then, and if she has to take hormonal therapy, for one or the other indications, then preferably give her transdermal rather than oral. And if she falls into a high risk group, then avoid MHT in her. Now, what are the current guidelines and considerations for CVD preventive therapies in women, which the statement has been given by American Heart Association 2023, published in Circulation Journal. So these are the journal guidelines and recommendations. Encourage optimal blood pressure of less than 120 to 80 millimeter of mercury through lifestyle approaches. So they have categorized the blood pressure. Normal is less than 120, systolic, diastolic, more than 80, stage 1 and stage 2 hypertension. Let's not go into the details because this is for the physicians or the cardiologists to understand. Now, lipids. Encourage optimal lipid levels through lifestyle approaches. So your LDL cholesterol should be less than 100 milligram per deciliter, HDL more than 50 milligram, triglycerides less than 150, and non-HDL cholesterol less than 130 milligram per deciliter. They have recommended statin treatment groups in clinical atherosclerotic cardiovascular disease, severe hypercholesteremia, diabetes, and primary prevention. Aspirin to be given in individuals with cardiovascular disease unless it is contraindicated. So low dose aspirin can be considered for primary prevention amongst select adults at high risk for ASCVD risk with low bleeding risk. Smoking cessation, always encourage people, because smoking is a very high risk factor, and then avoidance of even environmental tobacco is to be advised, and it is recommended. Diet. Diet emphasizes intake of vegetables, fruits, legumes, nuts, whole grains, and fish. And what should be limited? Consumption of saturated fats, cholesterol, sodium, processed food, especially meats, refined carbohydrates, and sweetened beverages. Exercise. Very, very important, preventive therapy, I must say, and it kind of, treatment also. Engage in 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous intensity aerobic exercises. Then additional cardiovascular benefit with 300 millimeter per week of moderate intensity or 150 minutes per week of vigorous intensity aerobic exercises. Weight loss and weight maintenance. Maintain or achieve an appropriate body weight through comprehensive lifestyle interventions, and higher levels of physical activity is recommended, more than 300 minutes per week if you want to lose weight. Then environmental exposures, assessment of exposure to environmental hazards like living near a highway, unregulated private well for drinking water, house built before 1978. I think this is all for the policymakers. They have to look into it. And recommendations based on cardiovascular risk also, like mask use, air filtration, and green spaces. Environmental justice initiatives like renovation of lead water pipes infrastructure, built environment, and green spaces all has been recommended in journal guidelines. So friends, you must have heard this phrase, दिल तो बच्चा है जी. यानी कि जितने भी बड़े हो जाओ हम बोलते हैं दिल तो बच्चा है. If you really want to make this phrase a truth, then we need to follow certain guidelines and healthy lifestyles. Otherwise, it's a myth. And what are these, heart-healthy lifestyle choices? As have been, recommended by SMS Health: stop smoking and even alcohol. Stay active, do exercise, eat right, maintain a healthy weight, and know your numbers. That is very important. Your blood pressure, your lipid, your blood sugar, everything. You must know your numbers and take medication as and when needed. So, friends, heart is the same, beats in same manner, but feels differently when you have different emotions, when you have different sentiments, and when you have different feelings. And let me, tell you how. So this is a beloved heart. You are under cardiac arrest for stealing my heart. This only can be felt if somebody is in love. You have a love for friends, you have a different feeling. When you have love for family, it's entirely different feeling. And when you have love and passion for IMS, Indian Menopause Society, it's entirely different. But the loveliest masterpiece of the heart by God is the heart of the mother. I think everybody would agree with me, which is her child's school room. And this is a poem which has been, written by our daughter Shagun Mahajan, who's a consultant breast oncosurgeon at Tata Hospital. Mother's heart is the centaurum of the divine temple. Bow to thee and worship it, to experience blessings from the cosmos, creating miracles beyond your imagination. Thank you. Thank you all for patiently.
Thank you, ma'am. It was really wonderful, very, very informative, and very nicely you have presented, and it even ignited a spark in us for the love and passion to develop for a menopause society as well. Thank you so much. Very excellent talk, ma'am.
Thank you, Dr. Monica.
Thank you, ma'am, for a very elaborate but very to the point and concise talk. It is really difficult to cover such a elaborate topic in 20 minutes, but really to hear you and this lecture is wonderful. And I hope we will be having more and more lectures, more and more lectures with you in our tenure.
And I would like to invite our own
Thank you.
cardiologist, Dr. Achal Tiwari, sir, to say a few words. He has joined.
Hello, thank you. Thanks a lot, ma'am,
Welcome, sir.
for inviting me.
For joining.
And I must congratulate Madam Sharma for elaborating and telling everything which I should tell or I was supposed to tell. And really, it was a very nice lecture by ma'am. And she completely have taken all the aspects and all the points. So definitely, she has given emphasis to all the points which should be uh, taken care, especially for postmenopausal women.
Thank you,
Thank you,
Dr. Achal.
Thank you for coming.
Thank you, ma'am.
Good evening,
Jyoti, you are
everyone.
remaining.
Good evening, everyone. Can I have little time to congratulate, first of all, Sudha Sharma, madam. Dil to bacha
Thank you,
hai
Dr.
ji,
Jyoti.
from Kashmir ki kali, from
Thank you,
the
Dr. Jyoti.
beautiful, a very beautiful deliberation by you, madam. It is always pleasure listening from you. You present anything you present in a way that really touches the heart. Not it uh, includes everything academic, but in a very pleasant way, so that
Thank
it
you.
can mug up in the mind and mug up in the heart. So this
Thank
is
you, Dr.
the
Jyoti.
this I always appreciate this kind of beauty of your lectures. So big round of applause for your lecture. Everything what you
Thank you.
have narrated, that included that हमको वापस उसी जमाने में वापस जाने की जरूरत है जहां से हम जिस सभ्यता संस्कृति से हम आए हैं. सो एवरीथिंग विल remain good, like you said about the leaving the smoking, for the diet, for our routine of the life, and for the for, you can say, inclusion of yoga and all things which can be implemented and give a better results. The current days, current scenarios, lifestyle is becoming so stressful that apart from our internal changes which are being happen because of age, they are being externally affected by so many things. And you rightly said that even where we are staying, where we are living, एक छोटे से गार्डन में जाने से फर्क अलग है और एक रोड के पास रहने से फर्क अलग है. These things are so important to take care, apart from the menopausal hormone therapy, apart from the any other thing. So we have all the solutions in our hand, but we have to go back to अपनी आदि संस्कृति में, then we can do it better. So it was really very beautiful to listen to you. I will also like to take this opportunity to congratulate once again Asha Jain madam, that she is streamlining the RMS things in a very nice way, in a very planned way, and she has a very nice team. I congratulate her, Dr. Vinaya, and all the friends who has given help in organizing these Twilight webinars and the newsletter. And special thanks to Dr. Shalini, who has continuously remain in contact with each of us to remain the part of this. And she is my very dear friend, and she is a very dedicated worker. So congratulations to each one of you. And I'm very happy to see Dr. Achal, my batchmate, and Dr. Nitin also here, Dr. Dilip Lalwani. So the new beginnings are, I can see here in RMS that the cross faculties are coming and becoming the part of the RMS webinar. So definitely RMS will do something something good, something special for the management of menopause. So again, big round of applause for everybody. Thank you for inviting me.
Thank you, Dr. Jyoti. You have,
Thank
you know, concised and you have put it in such a nice way, the whole extract of my talk. Thank you so much.
Thank you,
Thank
Seema
you.
Madam, Sudha Madam, for putting flavor of Jammu and Kashmir.
Thank you.
In your talk.
Thank you. I have been to Raipur 2 times
Yes,
when,
yes.
when Dr. Jyoti has invited. And it was such a great pleasure. I tell
You
you,
are,
I
you,
still
you are always welcome
I,
to the Raipur.
I still remember, and even Dr. Anil remembers the hospitality which she has shown along with her team. I will always remember that and cherish that.
Thank you, ma'am. Thank you so much. And thank you for accepting at a single call, because we have sort of just taken over and we are trying to streamline things, and the whole team is so supportive. So thank you so much.
Thank you so
you,
much.
Sushma, Dr. Jyoti, Dr. Monica,
Thank you, ma'am.
and where's my fourth chairperson?
Rupali.
She has not joined Asha Didi.
Okay. So thank you so much. Thank you, Sudha ma'am. And now we would proceed to the panel. Ma'am, if you have time, we would love you to stay over. But if you have to leave, then we understand that as well.
I will try to. You have invited such, faculty, important and eminent faculty, along with your, moderators and panelists.
So we start again. Once again, pranams to Vignaharta. And this is my guru, who says that you need to do everything excellently, and you need to do it. Whatever you do it excellently. Excellence in work, excellence in interhuman relations, excellence when none is watching you. Such excellence will come only when you are not enslaved and experience true freedom and dignity. So, with pranams to him, we start. The panel is on cardiovascular, mental, and ocular health. I'm moderating it, and the panelists that we have are really very, very eminent. So we have Dr. Rajni Sao, who's the director of Karma Hospital. She was president of Raipur Gynae Society 2008 to 10, member of many committees, VP of Raipur IMA 2008 to 9, General Secretary Raipur IMA, Secretary of Raipur Gynae Society, and currently she is the executive member of RMS and also ROGS. We have Dr. Achal Tiwari. He did his MBBS and MD from Pandit JNM Medical College, our own college, and he has done fellowship in non-invasive cardiology from Escorts, New Delhi. For the last 19 years, he's practicing in Raipur. We have Dr. Nitin Malik, who's an MD in psychiatry. He is director at Pragya Hospital. And this hospital takes indoor patients. He has a lot of work on de-addiction. He's done his MBBS from SS Medical College, Riva, MD in psychiatry from Manipal. His special areas of interest are licensed psychiatry and drug de-addiction. We have Dr. Dilip Lalwani, who has the Bhaskar Eye Care in Raipur. He has neuro-ophthalmology training. He has a gold medal in glaucoma session in Bhilai, platinum award. Because this is not our specialty, I don't even understand what is GIEP program coordinator. We will be glad to know what it is, sir. He's a life member of AIOS, GSI, CSOS, RDOS, IMA, and ACOIM. We have Dr. Jyotsna Gandhi Gupta. She's an MSDNB obstetric gynae. She is a consultant and director at Sadbhavna Hospital, Naya, Raipur. She was previously in MMI Hospital, Raipur. She specializes in high-risk pregnancy and lap surgeries. We have young, dynamic Dr. Sangeeta Pal, who's an MBBS MS, CIMP, trained in Foxy certified course in ultrasound and colposcopy. She's a member of ROGS, RMS, and ISOPAP and practices at Hope Health Hospital, Mana. She has the gold medal in Gynecon 2021 in the State Conference of Raipur. We have Dr. Prabhadeep Kaur ma'am. She's given a very short CV. She is the chief consultant at Jawaharlal Nehru Hospital and Research Center, Bhilai. A very senior, very humble gynecologist with very many DNB students under her, but she has chosen not to write anything. So now I would request all of you to gear up and we start with our first case. Madam has said a lot of things, so this is just going to be sort of a recap of what we all already know. Questions are not assigned to anyone. Any panelist can answer. So a 52-year-old postmenopausal woman with a family history of cardiovascular disease presents at her routine checkup. She complains of occasional chest pain and shortness of breath. So this is a very incomplete history. Other than cardiac cause, what could be the cause of shortness of breath?
Firstly, anemia itself, which is very
Yes.
common, it is very common in females.
Another thing,
Just sickling.
Any history of asthma, madam?
I think, when we were students, our teachers used to tell us that think of the common causes first.
Hypothyroidism can be a cause.
Hypothyroidism,
pulmonary cause.
Anyone thinking of obesity? Anyone
Asthma,
thinking of obesity?
Yes, ma'am.
It's the most common thing that you get. That she is so fat, she can't walk. She feels breathless. And that is the thing that we see most often these days. So now we come to the questions proper. Does menopause contribute to cardiovascular risk? And what are we as gynecologists going to assess in the patient before we send over to a cardiologist? Sangeeta?
Can I answer?
Yes, ma'am.
Yeah.
Ma'am, less
Go ahead.
estrogen in menopause can lead to less energy expenditure, and it can lead to more inflammation and increased oxidative stress. It can lead to endothelial dysfunction. So cardiovascular disease risk is more in this patient.
No, but what are you going to assess? What are you going to assess clinically and in the lab?
Yes, ma'am. First of all, we have to confirm the cause of chest pain and shortness of breath, if it is possible at our level. And we want to know history of other metabolic diseases in this patient, like diabetes mellitus. And we want to know about if she had any other comorbidity. And the year of menopause she has achieved. And as she has shortness of breath and chest pain, grade
we've
of,
lost her.
If there's any heart pain. Hello?
Yeah.
Hello?
Yes,
ma'am.
Please go ahead.
Ma'am, as she has two complaints, occasional chest pain and shortness of breath after exertion. So NYHA grade of heart failure, we want to assess that, and after that we want
Dear,
to
I'm
send her
asking
to
you
the
a
cardiologist.
very
Madam.
specific question. Yes, Jyotsna. Would you please?
Madam, first of all, with the history and the patient look, we can find out so many things, like the age at which the menopause occur, then the comorbidities, as the doctor said, is there any history of diabetes, metabolic syndrome, is there any past history of gestational diabetes, gestational hypertension, PCOS, smoking, depression, tobacco use, all these taken account in the history. Then when the examination comes, we can see the BMI, the waist circumferences, the blood pressure, which is very the basic thing, then we can go for this test. If we are looking for the blood test and the biochemical test, the first important test is CBC. As you said, the anemia is the most common cause of shortness of breath in Indian women. Then we will go with the fasting blood sugar and the 75-gram glucose tolerance test. We can go for that. And lipid profile, which is fasting in the fasting stage, because she has family history
Jyotsna,
of.
I would just like to interrupt you for a bit. How would you do a lipid test?
Ma'am, lipid test should always be in the fasting state.
How many hours of fasting?
8 hours of fasting, madam.
Dr. Achal, would you like to specify that? Dr. Achal? Sudha ma'am, would you like to just add a bit? How do we do the lipid test?
I think we have read about 12-hour fasting from 9 to 9 as of now. Yes. So no doubt there is a lot of debate going on these days, but no consensus has been made as of now. As of now, we go with the whatever we have read in earlier recommendations. That is 12 hours.
Okay. So now you may please go ahead, Jyotsna.
Yeah, madam. Then CBC fasting lipid profile, including apolipoprotein A, homocysteine level, CRP level. We can go if there is any history. As you said, there is history of family history of cardiovascular disease in her first degree relatives. Then we can go for the ECG. Basic test is ECG, madam. We can do that. And though there are so many risk score described in the literature, for the practical purposes, we are not doing these Framingham risk score test and all. For that, we always send the patient to the cardiologist for the further workup, like cardiac, this echo, TMT, stress test. Then
no, please let us take the question, break it into parts and let everybody answer. Because what I'm saying is, you already explained Sanjita explained the role that estrogen is going to play. So for a post-menopausal woman, what risk screening tools are appropriate? What are the tools that you're going to use?
Madam,
blood pressure, ECG.
That I have told, madam. Blood pressure, ECG, and lipid profile, fasting lipid profile, diabetes. These are the 4 main things, madam. And then ECG and echo.
Okay. Now, from here, we go next that you did everything and you found nothing wrong. Okay. Except that her lipid levels are a little disturbed and she is absolutely not used to exercise. Okay. She has an extremely sedentary lifestyle. She's a, housewife, and now Bahu is at home and, she is leading a very relaxed life. In that case, what non-pharmacological interventions can reduce cardiovascular risk? Rajni, I would like you to answer this, please.
Yeah. First of all, we have to see what diet she is taking, whether it is rich in fat or whether she is taking properly well-balanced protein-rich diet or not. She is having a good amount of liquid intake, water intake or not, whether she is exercising, she's doing yoga, she's de-stressing herself or not, or some kind of meditations. All this will help.
So what are the non-pharmacological interventions you would ask her to do?
I will ask her to regulate her diet, to balance her diet, to do a little bit of walking at least daily, few yoga, few breathing exercises. This all are the non-pharmacological intervention which will help in and reducing the stress.
Okay. So this patient, do you think she should be given HRT? Hormonal replacement therapy? Do you think she...
No, not now. Not now.
I want to ask that for cardiac health, just now Sudha ma'am has explained it very well. only to improve cardiac health do we give hormone replacement therapy? Is that
For
an
that thing,
indication?
for
No.
that thing, a good history is required. Where when did she was, whether she was in perimenopause or post-menopause, उसको कितने साल हो गए, वो that will actually determine
No, see,
how
agreed,
to
but
start the
the
MST.
question is very specific. For heart health, would you prescribe HRT? Is it indicated?
Actually, data and all the studies, some studies do say that it helps, but the large studies which have taken and over the years, it has not supported much. But in early stages, if the patient is having the vasomotor symptoms and all, then yes, the estrogen will help.
Okay, so for her breathlessness, you don't want to give her HRT. If she
Dr.
has,
Asha,
yes, ma'am.
can I say
I was
something?
waiting for you to come in.
So can I make the things
Yes,
clear
ma'am.
over here?
Yes, ma'am.
I
Yes,
just
ma'am.
need to tell everyone that there is no indication for HRT or menopausal hormonal therapy as far as preventive therapy of cardiovascular health is concerned. Yes, if you are giving MHT or menopausal hormonal therapy for some other indication, like Dr. Rajni said, for vasomotor symptoms or for some other indications, then definitely her heart is going to be benefited with it. If it is less than 10 year postmenopausal or less than 60 years. But per se, for cardiac health, no need to give any hormonal replacement therapy. That is the consensus and the guidelines and the recommendations.
So I had heard that, ma'am, in your lecture, and so I wanted to bring it up. Thank you so much for clarifying it again. So, chest pain in a postmenopausal woman, to differentiate coronary and non-coronary causes. How is the investigation different from men and women? How is it different? Ma'am had explained that, coronary symptoms in women are very different from those in men. So how should chest pain in postmenopausal women be investigated? Any panelist?
Normally, ma'am, normally there is more chances of unstable angina in women rather than the men. So by the history, we can get some clue, first of all. And secondly, ma'am, actually there are no different tests for women and men.
Agreed.
So
we have to keep a high suspicion level for symptoms.
Yes,
so
ma'am.
we don't just discard कि ये इसको mentally हो रहा होगा.
नहीं.
Yes, we should always see for whether there is any kind of metabolic syndrome that is present. That is, is there any kind of dyslipidemia? If a postmenopausal woman is presenting with a chest pain, she may not be having any previous history, but all the causes of this chest pain has to be evaluated, because she might not have shown previous signs, but she might be having coronary vascular disease in her case.
Okay. So do you want to go ahead and advise a TMT directly?
Yes, no, ECG is the first one that should be done.
ECG will only alter once there has been some kind of vessel block.
Rather than going for angiography, we can directly
Not
go in for
angiography, TMT. Do you want to go for a treadmill test?
Yes,
or a stress angio, stress echo?
Yes.
Stress echo and TMT.
We can go for.
Which one do you want? Stress echo or you want a TMT?
Pardon, ma'am, I'm not able to listen properly.
Means which one do you want to ask the patient to have? A stress echo or a TMT? What are the different indications for both of them? Both of them are not for the same indication, see? they are both looking after coronary insufficiency, but when do you do a stress echo and when do you do a TMT?
When there is chances of unstable angina, stress echo is better.
Stress echo is better. Yeah.
The thing is, the lady should be able to walk. She has arthritis. She's extremely obese. She's not used to walking. She will not be able to walk on your TMT machine. That is a basic thing. So basically, anyone who has, for some reason, cannot walk, that is a candidate for a stress echo or a stress TMT. There is also a stress TMT that can be done, where you inject medicine to increase the heart rate, and accordingly you are able to get the changes. So the indications are basically what the patient can do. She has severe arthritis, one leg is polio, she can't walk on the machine. So that we have to remember. We have to look at the complete physique of the patient, and then we proceed to the second case. Dr. Nitin Malik is here. So this is a case of 58-year-old postmenopausal woman. She complains of memory lapse and she has difficulty concentrating at work. We all know that the age of retirement is now 65 years. So she has another 7 years of her job to do. She has no history of psychiatric illness, doesn't say that she has any depressive symptoms, but she is worried that I'm not able to concentrate. I'm not able to remember. So I would request Dr. Nitin Malik to come in here, sir, and help us. What is the relationship between menopause and cognitive function? And how are you going to assess whether there's really cognitive decline in this patient?
Thank you, ma'am. I thank you. I thank Raipur Menopause Society for allowing me to be a part of this panel discussion, and this is, I think it's a very important topic: mental health and cognitive decline in menopausal age group. We frequently come across patients who are of the menopausal age, who are perimenopausal, and who come to us with something which is commonly known as brain fog, and who say that they are not able to remember things now properly. Their memory was very sharp initially, but now they are suddenly not able to recall things, not able to retain things that way. And in that age group, when they are approaching menopause, and sometimes even in people who have just become menopausal or a few years after menopause. So this is very common, and we all know that estrogen, it plays.
Actually, my question is, how are you going to assess whether she
I'm
has
coming to
cognitive
that.
decline?
Yeah, so there's a relationship between menopause and cognitive function, which and the cognitive functions which are commonly affected is the memory, the recall abilities, the verbal memories. All those things are the concentration, attention, all those things are affected. And how to assess a cognitive decline in a patient? See, there are many handy tools which can be used to assess, apart from the patient self-reporting, if the patient is reporting by self. So there's a very simple. There are a lot of detailed tools, but you need to be you need to have a training to administer them, and they are very lengthy. So, but there's a very small tool like MMSC, mini mental status examination, which is a 10-point. It's a tool assessment which you can keep on your table and ask the patient to fill it. It hardly takes 5 minutes to administer. And with this, that gives you a very good assessment about the patient's abilities, and you can have a serial assessment of that when the patient comes. And so you can have a fair amount of assessment about the patient's cognitive abilities. So an MMSC, knowing how to administer it, it has very simple things like asking the patient to draw the face of a clock or remember a few words and then recall it at the end of the session, and things like that. So that gives a very fair amount of assessment. So just learn how to do an MMSE, keep an MMSE at your on your table and administer it. So that would be a mental status examination. That's all.
So would you share the questionnaire with us?
Yeah, sure. I can share that with you. Sure.
Thank you, sir. Thank you. So this whole question is just for you. So this is for a gynecologist. How do fluctuations in estrogen level affect brain function and memory? Sita, you want to answer?
Basically, estrogen is necessary for the health of the neurons and the neurotransmitters function, and in that way it affects the cholinergic, anticholinergic, antimuscarinic factors, and also it has an anti-inflammatory effect, and inflammation, a mild level of persistent inflammation is also recognized to decrease the cognitive health of a female in postmenopausal state, and in that way the estrogen helps in the brain function, keeping the brain function intact and memory intact.
Okay, thank you so much, Prabdeep ma'am. Now, sir, in
I
your
would like
experience,
to add one more thing.
Yes, sir.
Estrogen even leads to, it also acts on the hippocampus, which is the basic seat of the memory, and it leads to an increase in the dendrital connections there. It leads to propagation of dendrites there. So it's very important for that. Even in the frontal cortex and the prefrontal cortex, estrogen receptors are abundant, which where it acts and it leads to a release of dopamine. Then it's also important. Estrogen is important for the release of serotonin, which is we all know is very important as far as depression is concerned. So it's a very important hormone as far as the brain functions are concerned.
Okay. So, sir, I was coming to you that in postmenopausal women, what are the disorders that are most prevalent? And what is the basic screening that you would do here?
The mental health disorders which we see in postmenopausal women as such, apart from the cognitive things which we have talked about, if we look at the mental health issues, it's mostly anxiety and depression, which are the two most common things with which patients present to us. So they can be of varying levels, right from depression, starting from a low-grade depression, which we call as dysthymia, up to a very severe kind of a depression where the patient goes into a severe depressive episode, and anxiety, which can manifest in various forms, from a generalized anxiety or a panic attacks or panic disorder to patient presenting with OCD. So anxiety in various forms, all these things are very common in patients who are now in postmenopausal. So this anxiety and depression in various forms are the most common mental health conditions which we see in postmenopausal.
So in patients who have a previous history of schizophrenia in the family, is there a precipitation of schizophrenia also at this age?
That can happen. I won't deny it, because see, any kind of a psychiatric illness, the precipitant could be any stressor. So a menopausal patient going into a menopausal state, it's a transition. It's a big life transition. So any kind of a big life transition is a stressor. So any kind of a stressor can lead to a precipitation of a psychiatric illness. So if the patient has had a history of schizophrenia in the past, was well controlled, now starts becoming menopausal. So now this is a life stress. It's a life event. So now this can result into a precipitation of the schizophrenic illness.
Okay. So this is for my gynecologist, that do you think diet, exercise, and meditation, etc., are going to have an effect on the cognitive decline? Do you think they will help to reduce cognitive decline?
Yes, definitely.
Yes, ma'am.
Definitely?
Yes, ma'am.
Ma'am,
it basically
ma'am, it will reduce vascular damage.
Yes.
Not
It
particularly
basically
diet
helps in
and
release of feel-good hormones. It decreases the oxidative stress. It decreases the inflammation, and it stimulates the neurons. It shapes your body and make you feel good. And in that way, it helps to increase the confidence of the patient, and the mood is elevated. And also the positive effect on the hormone status of the patient, like serotonin release and all. It helps in the cognitive health of the menopausal woman.
Okay. So here I come back to that same question that I had come to for cardiovascular health. That if somebody has cognitive decline but no other symptom, would you prescribe HRT to prevent it or not?
And there's no
What
recommendation.
Yes, Sanjita.
what
That's
books say
Sanjita, right?
is that early addition of the estrogen in the treatment, I mean, hormone therapy only for the cognitive health is not recommended. But if again the same thing, if it is started because of some other reason, then it might definitely help in the improvement of cognitive health of the menopausal woman. But it
So,
has to be early intervention.
So I come back to you, Nitin sir. Are there any pharmacological treatments or supplements recommended so that this cognitive decline can be decreased?
As such, specifically for the postmenopausal cognitive impairments, I'm not in the knowledge of any specific thing for postmenopausal cognitive impairment, any pharmacological supplements. Yeah, a lot of supplements empirically have been proposed as far as cognitive impairments are concerned. So naturally, all those can also be tried for postmenopausal cognitive impairments. There's no specific treatment for cognitive impairment only, but if this cognitive impairment is a part of a larger process, like if the patient has anxiety or patient has depression, which is leading or increasing the cognitive impairment, so then naturally treatment of that anxiety or depression will help in improving the cognitive impairment per se. As far as I would just like to add in the previous question also, the hormone therapy thing. There was, I think, I do not remember exactly when I was going through the literature, there was a big trial which was done of hormone therapy in cognitive impairment before. It was a long time ago where they found that giving hormone replacement therapy to females actually worsened the outcome. But then it was found that it was mostly in elderly females who were more than 60 years of age. And then when they looked into it again, they found that in females who were in the age group of between 50 to 60, it actually caused a bit of improvement in the cognitive function. So then now there's a line of thinking that if you give HRT initially or in the perimenopausal kind of an age group, it might actually help in improvement. But I am not aware whether there are concrete recommendations for starting it for cognitive decline per se. But there are studies which say that starting it initially might show improvements, but after the age of 60 years, it is not recommended to start it, because when there's a neuronal damage which has already occurred, giving estrogen will actually worsen the damage, and so it will not help.
Thank you, sir. Thank you. Sudha ma'am, would you
I
like
would
to
just
add
like to
something here?
add on something like in my practice I've seen like assessment of vitamin B12 level, the whether vitamin D3 level, the proper protein intake, calcium intake. Just assessing and fulfilling all these simple items also helps in the generalized wellness and means not as such the neuronal.
Agreed. That is the deficiencies that you are correcting. Yes, Sudha ma'am.
But it helps in the mental and neuronal preventing the damage further.
Okay. So I fully agree with Dr. Nitin that this is a women health initiative study, Dr. Nitin. which has
Yes.
been, published. And then this study was followed up. All those females who had given the consent for follow-up, it was followed up for 20 more years. And whatever they have found, you have very, nicely, you have depicted it that before, late age, less than 60 years, it gives some kind of improvement in the cognitive function. But overall, there is deterioration as well. So it is a controversial thing, whether to give, whether not to
Yes.
give, but no recommendation to give in improvement of cognitive decline. Number two, I want to share one thing, Dr. Asha, where you have, touched the lifestyles and the meditation for cognitive. There is one study which has been done in AIMS, Delhi. It was a case control observational study, and they have selected few, two groups, wherein in one group, all those persons who had, done chanting of Gayatri mantra for a certain specific period, they found that there was improvement in cognitive function, maybe because of some stimulating effects on the frontal cortex. So they have found it, though it is a small study, but definitely they have found it. So maybe some kind of meditation and some kind of, reciting these mantras, or maybe it can help stimulate the neurons. Thank you.
Ma'am, even I would like to add that yoga was found to be the best mind-body intervention which could be done to improve the cognitive decline in postmenopausal females. So this was actually done in a study, and it was found to be very helpful, yoga.
One line I would like to add, Asha Didi.
Yes, please.
Meditation, diet, yoga, everything has a great thing, and research is also going on. Dr. Mrityunjay Rathore in AIMS, anatomy department, he is doing various researches also, and he is connected to various bodies also, and he is spreading this through various groups. If you would like to be added, I would give your numbers, everyone. जो भी add होना चाहे, it is a very good thing, and he literally spread the things ki brain ke kaun se area mein meditation is working, the Brahmari chanting, everything, pranayam, pratyahar, many things, doing let go, attitude, and it is a really wonderful thing to be known by all the females. I really want that if anyone is interested, I would ask him to let you join.
Yes, ma'am.
So you can just share the link, dear. You can share the link.
Yeah. I cannot share the link because it is admin group, so I can request him to join you people.
Okay.
If you can directly message me.
Okay. So now we go to the next. What I find in my life, and when I see around all the gynecologists, for them, 60, 65, 70 is just a number. Anju ma'am has become vice president now. She was before that. All these super women who are in IMS and even in Foxy, age is just a number. So the basic thing is that you need to have a reason to leave the bed in the morning. If there is some motivation for you, something to look forward to, many of the things are taken care of. The whole problem is when you're not motivated enough. You don't have anything to look forward to, and all the problems will happen. So with that, I think I'll take the program forward, and you might have to carry on for a minute because this battery is going. Just a second. इसकी बैटरी ऊपर से लेके आ, दौड़ के तार लेके आना. So now we proceed to the next case. What is the mechanism of developing hypertension post-menopause? What is the mechanism? Why not before and why after?
It is basically the loss of the protective effect of the estrogen that contributes to the hypertension developing post-menopausal. And the endothelial dilating effect of the estrogen through the nitric oxide is lost. The vasoconstrictor endothelin 1 alpha, that is increased because of deficient estrogen, is one of the cause for hypertension. And also this fibrinolysis at the coagulant effect of the loss of estrogen, that increases the plaque, that results in atherosclerosis and all. It results in stiffening of the artery as well. And all these results in hypertension in postmenopausal states.
So, is the management of hypertension different in a postmenopausal woman compared to a man, or it's the same?
Otherwise, management is almost similar, but we can have lifestyle modifications that will improve the state for the menopausal status. I mean, the HRT as well, the early initiation of HRT, that can prevent menopausal women entering into this hypertension and cardiovascular disease scenario.
Okay. So, what is the first line of antihypertensive? Would you give it, or would you advise the patient to go to a physician, or you want to write your prescription yourself?
Thiazides are the first line of drug, madam.
Which drug did you say?
Hydrochlorothiazide, thiazides.
Okay.
Contraindicated, ma'am. These are the, I think, for women, they should be added when we are prescribing antihypertensives.
Anyone wants to differ
in
on that?
uncomplicated hypertension.
They say that calcium channel blockers and AC inhibitors are quite good, and they have to be clubbed with diuretics accordingly. But still, I would prefer to send the patient to a physician rather than treating her myself.
Okay. So if she is overweight and has a little bit of metabolic syndrome, and she also has that, 140/90 BP. So would you advise her weight changes and other things before you send her, or you would send her directly?
No, definitely lifestyle management has to be advised, because even decrease.
Whenever there is any associated risk factor like metabolic syndrome or diabetes or something like that, ma'am, then the target blood pressure should be less than 130/80. So instead of only drugs, we should always combine lifestyle modification.
Other than the direct effect of the weight change or exercise, what is the added effect? In your experience, when you advise a patient, you do some walking, you reduce your diet, what is the additional effect that it has other than controlling her blood pressure and lipid? Think a little of mental health.
Yes, ma'am. Exercise always induces endorphins.
Yes. And it makes her feel in control, that she is able to do something. सब कुछ हाथ से निकल गया वाली जो feeling है ना, that is not there. So that helps in motivating the patient as well.
They feel good when do they exercise.
They feel good.
Yes, ma'am.
And do you think HRT will reduce her blood pressure?
No.
No, ma'am.
No, ma'am.
No, ma'am. It is not
in fact
advisable to add HRT at this stage when she is going to.
So we all agree on that. And now again, we are back to Nitin sir. This is a 53-year-old who presents with increased anxiety and low mood following menopause. She has difficulty in sleeping. She's very irritable and has no interest in her routine activities. Even the puja that she used to do, she feels, ye sab kyun karna hai, nahi karna hai. There's no previous psychiatric history. So what is the relationship between menopause, hormonal change, and onset of anxiety and depression? What is the relationship?
Yeah.
Yes. Sorry.
Yes, sir.
Yes, yes, yes. No, I would like you people to please, because
No, sir,
Okay.
please, we will be enlightened with you
no,
by
I
your
think we have
talk.
discussed this.
Do
We have
proceed.
discussed this in the previous this thing also. We discussed the relationship between menopause, hormonal changes. So there's
Okay.
a
So this
direct
is just a
there's a direct
repetition.
relationship. We can think about it as a direct relationship and an indirect relationship. Okay. So menopause has a direct relationship through the changes which happen in the brain because of the hormonal changes due to menopause. So that we have discussed the effect of the on the brain, the effect on the serotonin levels, on the dopamine levels, all those things which lead to the increase in the anxiety, depression. The indirect changes, indirect causes of anxiety and depression, which is because of because of the physical changes which happen because of menopause, which can be very distressing to the female. Then there are other issues which happen. There's a change in libido. Then there is the relationship issues which happen. Then there are then it's a time of transition for the female, so there is a lot of irritability. Then then there's a feeling that she's not being looked after well, she is not being understood by the family members. So all these things they take a huge toll on the psychological well-being of the person, and so that leads to a lot of anxiety and depression. So menopause in itself, not only directly but indirectly and through many ways, leads to anxiety and depression.
So how would you differentiate, sir, whether this is anxiety or is it depression or is it some other serious psychiatric condition? Because what you are talking about is reactive depression, right?
Yes, it could
So
be.
a reactive depression, anxiety, and the illness wala depression. How are you going to differentiate that?
Ma'am, whether it's reactive depression, whether it's anxiety, or whether it's what you are saying is illness wala depression, is for us, we follow certain parameters or certain guidelines when we are evaluating a patient who comes to us with symptoms of anxiety or depression, and then we make a diagnosis. So now, even if the patient has anxiety, which is because of menopause, or whether the patient has low mood, which is because of menopause. So for us, if the patient is satisfying certain criterias, like say, if the patient has a significant amount of low mood, which or sadness, which is persistent throughout the day and has been suffering from it for the past 2 weeks. If the patient has something which we call as anhedonia, that is just disinterest in all pleasurable activities, which is there. If the patient has a uh, lot of anergia, that is a lot of decrease in the physical energy. Apart from that, there is a change in the biological functions. There's a decrease in sleep, there's a decrease in libido, and there's a decrease in appetite, and irritability is also there. And all these things have been persistent for the past at least 2 weeks. So now that patient falls into the criteria of a clinical depression. So whether the cause is menopause, but the patient falls in the criteria of clinical depression, and the patient has to be treated as a patient of clinical depression. So immaterial.
Okay.
So that is
So,
immaterial.
sir,
Whether
would you want to give her HRT?
see, for starting the patient straight away on HRT, whether HRT would be
She is
beneficial in the
53
long
years
run.
old. She is
Ma'am?
53 years old. Do you want to start her on HRT?
Ma'am, as a psychiatrist, I would not like to start the patient straight away on HRT. I would leave that decision to my gynecologist friend. So
let me
maybe
ask your gynecologist friends, sir, whether they are going to give her HRT.
yes. If I have diagnosed the patient as a case of clinical depression, I would like to start the patient on antidepressants, or maybe consider the patient for a treatment of depression, whatever would be the best course, whether I'll straight away start out with antidepressants, or I would go on for treatment with non-pharmacological managements, whatever. That is the course which I'd like to plan for the patient. But for HRT, I would like the patient, I would like my gynecologist friend to decide.
So, my respected gynecologist, are you going to give her HRT for anxiety and depression? She is 53.
No, ma'am.
See, she has sleeping problem and she... No?
No, ma'am. Instead, straight away starting HRT, we would definitely will start with some antidepressant or anti-anxiety drugs and some supportive drugs. Straight away.
So I'll tell you my experience. I have a young patient. She's 47. She is perimenopausal. No. She is postmenopausal at the age of 45. She was under treatment for 2 years. Psychiatrist, physician, this, that, everything. And her husband was thinking कि ये पागल हो गई है. But she has responded beautifully to HRT. She's back to normal. Everybody feels that she is back to normal. So I think when the patient is not very old, you need to consider it, because she was under treatment for 2 years with zero response.
Yeah, I do second this opinion, ma'am, because even in my practice, I have seen that adding MHT in early ages of perimenopause or just within the 10 years of menopause, that actually helps.
And one more thing I want to ask my gynecologist, I'm going straight away to question number 6, that if the woman has sleep disturbances, she's unable to sleep well at night, she's having problem in sleeping, what is your suggestion to her? What are you going to advise her?
Ma'am, we tell her to
can also
make her bedroom quiet.
Yes.
Hello.
And
ma'am, we tell her to make her bedroom quiet before sleep, not too hot and not too cold. And we tell her to do exercise daily, but not close to bedtime. We tell her to avoid large meal at bedtime, and we tell her to stay away from caffeine, smoking, alcohol.
And
going to sleep.
We tell her to do yoga
daily.
Yes.
And even Tratak-like things also help. Doing Tratak.
One thing I would like to tell you is that you have to ask her not to sleep in the day. They say that we are not sleeping at night and they are sleeping all day, taking multiple naps. So once after a certain time, you need to earn your sleep, and you have to earn it by not sleeping in the day. You need to be productive and active in the day and then sleep at a fixed time, following all the suggestions that are given here.
Yeah. This
if
is a sleep.
Somebody has started taking etizolam. Nitin sir, this is my last question to you. So somebody has started taking etizolam for going to sleep. Doctor has advised initially for 10 days. Now they are taking it on their own. What are the side effects you see when a patient is prescribed antidepressant, anxiolytic, sleeping medicine in this age?
Yeah.
What are the side effects?
If you are prescribing, if the patient has been prescribed a benzodiazepine for sleep, then you should be very careful, because benzodiazepines are habit forming. We all know that, and you have to be very cautious in prescribing benzodiazepine to a patient who has difficulty falling asleep, because all said and done, availability of benzodiazepine, they can get it, and then they keep on abusing it. So it becomes a problem later on, and tolerance develops, and the patient keeps on increasing the doses, and later we find it very difficult to wean the patient off the benzodiazepine. So if the patient is on etizolam, has been prescribed for 10 days, then we should make it sure that the patient takes it only for 10 days and not more than that. So
there is another drug that is lonazep.
Yeah, it's clonazepam. It's again benzodiazepine. So
means patients take it for years together and they are not ready to let go.
See, whatever criterias we have, we generally give benzodiazepines for a period of 3 months. If the patient, even in patients of panic disorder, we give benzodiazepines for 3 months, and then we plan to taper those benzodiazepines and stop. Benzodiazepines have to be tapered and stopped. So just remember that, because otherwise, if you try to stop them suddenly, the patient will go into a rebound kind of they will have a rebound phenomena. So they have to be tapered. Please also remember, I like to emphasize this again. People think that zolpidem is something which is very safe and it can be taken. But please remember that zolpidem is also very highly addictive. So if you are prescribing zolpidem even to your patient, we make it sure that the patient takes it only for those days till you have prescribed it, and not more than that, because they can get Zolfresh or something over the counter. So it's also very difficult to. I have seen patients who are taking 40 to 50 Zolfresh every day. I have seen patients who are doctors. So it becomes very difficult to take it off. So any kind of a sleeping, a pill for sleep, if the patient is taking it for depression or anxiety, it is easier. But if the patient is taking only for sleep, then it becomes very difficult. So the best way to manage sleep is go for something non-pharmacological, educate the patient about sleep hygiene, educate the patient, encourage the patient to go into things like yoga or yoga nidra or those kind of things, and those help. It's not that they do not help, they help. Taking a benzodiazepine is a quick fix kind of a way. So if you encourage the patient.
What about melatonin, sir?
Melatonin, yeah. See, melatonin also helps. In few patients, it helps. You can take it up to 10 milligrams a day, and patients are, it's also available over the counter. It's considered as a food supplement basically. So it's available. And but then again, you have to remember, it is also anything you take for sleep and you take it every day, you will find it very difficult to leave after some time till you do something else to improve your sleep. So you have to do something else. Otherwise, you will be taking melatonin every day. So
I told you, earn your sleep. Earn your sleep.
So the best thing is, as somebody said, sleep hygiene. Educate your patient about sleep hygiene. After 5 o'clock in the evening, do not take any caffeinated drinks. Do not take Coca-Cola, Fanta, anything in the evening. No coffee. Okay, do some regular exercise in the night. Take a hot water bath. Okay, and do not keep your TV in your bedroom. Never. Okay, use your bed only for bed-related activities. Do not read, do not study or in the bed. Do not eat in the bed. Okay, and in the night, if you lie in the bed awake, read a newspaper. Do not watch TV or watch your mobile in bed. So these kind of small things always help to improve somebody's sleep. So all these things have to be done, and I cannot emphasize more how important these things are to improve a person's sleep.
Thank you, sir. Thank you. With that, now we come to Dr. Dilip Lalwani's questions. Sir, if you are there, would you just switch on your video? And these are questions for you. Thank you, Nitin, sir. Thank you for sparing so much of your precious time.
Thank you so much. Thank you. I thank the whole panel. Thank you so much.
Thank you, sir. Good discussion.
So
Thank
there's
you.
a 60-year-old postmenopausal woman. She complains of persistent dry eyes and occasional blurry vision. She doesn't have a history of ocular disease, but has noticed these symptoms since menopause. So what is the effect of menopause on ocular health?
Hello, good evening to all.
Yes, sir. Yes, sir. Sir, video, please.
For inviting me for this panel.
Sir, your internet is interrupting.
Anybody wants to say something?
Ma'am,
Yes.
during menopause, decrease androgen, estrogen, and progesterone production lead to damage to meibomian gland and lacrimal gland. Lacrimal gland produce tear and meibomian gland produce oil. So the protective layer of oil is gone. So there is more tear evaporation. Eyelid is inflamed. Then there's a decreased tear quality and production, and it lead to dry eye syndrome.
Okay. So how are you going to manage this? What is the non-pharmacological treatment that you're going to do? Yes.
Practices like giving warmth to the eyes, giving rest to eyes while seeing continuously to the screens, then keeping oneself hydrated, taking supplements like vitamins and omega-3 acids. These all might help in preventing the development of dry eye, and certain pharmacological preparations also do come for that. Those can be tried.
So what is the
artificial tears?
Pharmacological, artificial tears like things can be done.
Can be
so
tried,
do you
yes.
think that postmenopausal women should have a regular eye checkup?
Yes, ma'am.
Yes.
Because estrogen is neuroprotective. So decreased estrogen level can also affect the vascularization and chorioretinal function. So there should be essential eye test once every year.
Okay. We have lost Dr. Lalwani. Sir, you want to
I'm
add
here.
something?
Yes,
sir.
I'm here. And
Yes, sir.
at the outset, my
His internet is not working. Not working. So I think we proceed to the next case. Yes, sir. We proceed to the next case, which is the last case, that there's a 57-year-old postmenopausal woman. She has a sedentary lifestyle. She's obese. Now she's putting on more weight. There is increase in abdominal fat and elevated fasting sugars. So what is the effect of menopause on developing metabolic syndrome?
Again, the decreasing estrogen is the culprit, and at menopause, because of that, there is abnormal fat distribution. The centripetal fat distribution occurs, and the waist increases. The lipid profiles get deranged. There is increase in LDL. There is decrease in HDL, and increase in VLDL, and all that results in metabolic syndrome.
So if now, she has her tummy is increasing in size, there is central obesity. Means we always say, the pear and the apple.
Yeah.
The female is the pear. Now she is getting that apple type obesity. So is it dangerous? And if it is dangerous, then why?
Ma'am, in adipose tissue, if there's more adipose tissue, then there is more aromatization of androgen to estrogen. So it will down-regulate the hypothalamus and there's less FSH. So there will be less estrogen and there will be more calcific plaque, more damage to the vessels, and less energy expenditure, more inflammation that can lead to more metabolic syndrome.
Okay.
And
So
also,
what
I
about
would,
the effect on insulin sensitivity?
Ma'am, insulin
I would like,
resistance.
Yes. Any effect on insulin sensitivity?
Ma'am, less energy expenditure lead to more oxidative stress and there will be more tissue damage. So there will be more insulin resistance in this patient.
Also, if there is more fat, there is less muscle. So
Yes,
insulin utilization also becomes less. So if you want to, talk to your patient, what are you going to advise her regarding her lifestyle? We've already discussed she's sedentary.
Ma'am, there are many risk factors in this patient. We will say that you should take a diet less in fat, less in sugar. Ma'am,
okay.
Ma'am, more fruit and vegetables. Increase calcium in her diet.
If she has insulin resistance, would you advise her more fruit?
No, ma'am.
Agree. So if she has insulin
exercise,
resistance, she has to
exercise
add,
is the one that
yes. Exercise is very important and
will help her in increasing the and that is the main thing that we should advise to this patient because of her sedentary lifestyle and the increased abdominal fat and all.
So she has to include protein. She has to increase exercise. And what I find useful in my practice is to tell patients to walk for 15 minutes, 1 hour after every meal.
Yes, ma'am.
Because that is when your sugar is rising. So 1 hour after every meal, walk for 15 minutes, wherever you are. I find that really helps. So is this patient a candidate for HRT? She doesn't have any estrogen deficiency symptoms. So is she a candidate for HRT?
No.
Ma'am, oral HRT has an effect on C-reactive protein and protein S. If needed, the transdermal route is better because there is no first pass metabolism.
This patient, does she need it? That is my question.
No.
No, ma'am.
Now, no. So here the answer is no. Now she has untreated metabolic syndrome. Supposing she doesn't listen to anything you say. So what are the long-term risks that she has?
Ma'am, almost double risk of cardiovascular disease, increased risk of myocardial infarction, stroke, developing diabetes mellitus, and there's increased risk of mortality also.
Okay. So there is increased risk of everything.
Yes.
So thank you so much. Dilip
Now,
sir,
Dr.
we
Dilip has
could not
joined.
hear you. If you
Dilip
have
sir,
anything
we
to
want
add.
to hear you. We want to hear you. Dilip sir has joined with some other device.
Good evening. Sorry. Yeah. I have joined from my mobile. So can you hear me all?
Yes, sir. We can hear you.
Yes, sir. Sorry for interruption. So I heard a lot of you are using lubricating for dry eye disease. First of all, I would thank to RMS Society and Dr. Asha Jain for inviting me this panel. And let us have some questions to clarify.
Your voice has disappeared again.
थोड़ा सा रुक जा. Yeah.
That thoda sa ruk ja we could hear, but we can't hear what you are saying.
No, आपको नहीं बोल रहा हूँ मैडम, मैं आपको नहीं बोल रहा हूँ.
No, I
Actually,
know. That's what I'm telling you.
हाँ,
Please
अब
proceed, sir.
तो actually estrogen and testosterone, both hormone are responsible for maintaining the tear film stability and production of tear film. So if you have to go for rapid assessment for any postmenopausal woman that she has a dry eye, what type of dry eye, so first assessment should be clinical, whether she has a feeling, gritty feeling, or any other itching, redness. So this is a clinical symptom which can you proceed for next test, that is a Schirmer test. So if Schirmer test is a tear film test, you are applying tear film strip for 5 minutes and wait for 5 minutes and see how much lubrication that strip has went forward. So if less than 10 millimeter is there, so she has a moderate, mild to moderate type of dry eye. So if mild to moderate type of dry eye can be easily treated in anybody with the help of artificial tear like carboxymethyl cellulose and sodium hyaluronate. So these two drugs are very useful for mild to moderate dry eyes.
Thank you, sir.
And yeah.
So I would request everyone to put on your videos so we can take a picture for the newsletter. Everyone, would you please put on your videos? We can have one photo for the newsletter.
Thank you, ma'am, for this beautiful and interactive session. We enjoyed a lot, ma'am.
So I would now request all my panelists to give, everyone present here to give one take-home message before we end the session, and Shalini gives a formal vote of thanks. I thank all my panelists for being excellent and giving their time. Thank you so much.
Thank you very much. Thank you very much.
And yeah, one take-home point. Sanjita, we start with you. There's a lot of shaking at your end, and you are muted.
Ma'am, we study about all these things, but MHT के बारे में हमें इतना knowledge नहीं था. ये जो panel discussion के बाद मैम बहुत सारी चीजें आपके थ्रू और मैम के थ्रू, मतलब मैम के थ्रू जो पता चली उससे बहुत ज्यादा knowledge मैम हमारा बढ़ा. मैम, thank you for this session, मैम.
Thank you. Dr. Rajni.
जो टेक होम मैसेज मेरी तरफ से है वो तो आपकी बात सही है. देयर शुड बी अ मोटो एम कि आगे हमको कल जो देखना है वो किस लिए हम जगेंगे और हमको क्या करना है. दैट शुड बी इन आवर माइंड. मतलब लाइफ यूजलेस नहीं हो जानी चाहिए आफ्टर एज. तब जो है वो जाके एक फ्रूटफुलनेस रहती है और कुछ भी करने की इच्छा जो है बलवती रहती है. एंड दैट हेल्प्स in the further survival in a good manner, and good lifestyle, good eating habits, good exercise, walking and everything, and weight management. That is very important.
Thank you. Jyotsna?
Madam, for me, the take-home message is like, as Rajni Madam said, is lifestyle changes, and only thing we have in our hand is lifestyle, because we can't do anything without exclusion. After listening to this webinar, I'm scared also. What will happen to me when my estrogen level will decline? So only thing in my hands is my lifestyle. So for that we have to work from very starting. Like we cannot immediately go for the walking, so we should have a habit of walking. diet, proper diet and meditation. I think Dr. Shalini Jain and me, we have discussed 3-4 days back कि meditation का कितना ज़्यादा role है आजकल हमारे stress management में. So for me, again, this has been strengthened. This feeling has been strengthened that meditation, lifestyle, exercise and sleep hygiene. These are the three things which are in our hands or in any menopausal patient, for any menopausal patient.
Ravdeep ma'am. Thank you, Jyotsna.
Thank you, ma'am.
Ravdeep ma'am.
She left.
No, she's there. I can see her on my screen.
Achha, okay.
Ravdeep ma'am, one take-home point from you.
Her net was unstable.
Ma'am, for me, it was like we need not to take the symptoms of postmenopausal women in a lighter note.
Yes.
And we should always see what they are suffering from. We should give importance to the complaints that they are giving. And no doubt, lifestyle management is the big thing that has to be advised to every postmenopausal woman.
Thank you. Thank you so much. Monica?
Thank you, ma'am.
You've been
It
here
was a
through the
very
evening.
nice
Thank you, ma'am.
webinar, ma'am, and really benefited from that. Thank you, ma'am.
Thank you. Thank you. Dr. Monica?
Yeah, thank you, ma'am, for making me a part of it. Of course, it is our
You are
team.
the team.
Yeah, that's what I'm saying. Of course, we all are a part of it. And thank you, Shalini, because you reminded
No thanks
me.
from you. I want a take-home point.
Yes.
From you, then from Rashmi, then Saurabh.
I'm coming to it. Most important thing what I learned, madam, apart from diet, lifestyle management, meditation and everything, that we should focus on the symptoms. We should not just ignore it. The moment any patient complains, ये नहीं सोचना चाहिए कि अरे ये तो होता ही है. No, we should keep, we should be more focused on her complaints, and accordingly we should investigate her so that we can, pick up the cardiovascular things, her anxiety, her depression part, her ocular symptoms, all these, if we pick up in a proper time, we can help her, and she can have a very good lifestyle, and she will be more confident and more healthy then. That is a part which is our responsibility, I suppose.
Thank you. Thank you. Rashmi? Rashmi?
Ma'am, very, very well moderator you are. You have made the question so simplified, and every question we have learned a lot, ma'am. It was very good, and the best thing, yes, self-motivation is needed to do everything. And I have learned a lot today, especially cardiovascular is such a thing that sometimes we think, oh, it has to be treated by physician and that, but today you have made the chapter very clear. Thank you.
Thank you. Thank you. Saurabh, are you there? One take-home point from you.
Ma'am, lifestyle modification and diet, you have to explain to the patients. But in my practice, I have seen no patient, not even a single patient is following diet, which we advise. They are not doing exercise. They are not taking proper diet, actually.
So that is where the role of motivation comes in.
Yes,
unless
it
you
is not
are
only with
motivated,
patients, Saurabh.
nothing will
It
happen.
happens with us also. We ourselves are also
not doing
So Ritu,
we neglect ourselves so much.
Are you there? Dr. Nitin, would you like to say a few words? Shalini, I thank all of you. Thank you so much.
Sushma is remaining.
Sushma, one take-home point.
Wonderful webinar, and all the questions are very practical and useful for our day-to-day practice. I loved the whole webinar, and I must congratulate you for a new beginning of RMS. And while leaving the RMS as a president, I was thinking how it will go, I don't know, but you have taken the charge in a very appropriate manner, and you are coming with the new things. So I must congratulate the whole new team. And secondly, already everything was discussed. I just want to add one thing. We can always use menopause as a window of opportunity for investigations. Whenever patient comes to us for any problem, for UTI, for white discharge, for blood pressure, for diabetes, anything, whenever patient comes to our hospital, we should use that opportunity as a window of opportunity for various investigations, and we can guide her regarding the lifestyle modifications, dietary changes, exercise, and about the lipid profiles. So this is very important because we can treat the UTI in 5 to 7 days, but we will miss the patient for the next 6 months or 1 year. So it is my message to all the gynecologists that we must use this age as a window of opportunity for various tests, for breast examination, for cervical examination, for lipid profile, for sugar, everything. We can use this.
I would add cervical cancer screening.
Yes.
Cervical cancer screening, get an eye checkup, just get a thorough overhauling, because that is one opportunity that you have. So thank you so much. Shalini, you want to give the formal word? One thing I want to request all of you, please go to YouTube and subscribe to the channel, because this is a new channel and it has to live.
Already done.
Already subscribed, ma'am.
Yeah, but please spread it with your friends and everyone. Let everybody subscribe,
Yes,
because all our events will come up on this channel only. Okay?
Sure.
Over to you, Shalini.
Yeah, I really want to thank our own president, Dr. Asha Jain Didi. And I want to thank Dr. Anju Soni Madam, who is our president IMS and who has given time to us and did the unveiling of our first newsletter, whose editors are Dr.
Net issues.
Net gone. So thank you, everyone.
Thank you, ma'am. Thank you, everyone.
Thank you, Asha
Nice
ma'am.
evening
Thank
ahead.
you for
It's a
giving me the
working
opportunity.
evening.
Thank you very much.
Thank you so much. I'm ending the session. Thank you. Goodbye.
Thank you.
Thank you, guys.
Bye.
See you again.